Okay, well, good evening to everybody and welcome. You might notice a couple of people have used the Q&A to let us know who they are. So please feel free to do that because it's very nice to know who's in the Zoom room with us. I'm Simone. I'm in Sydney. I'm on country of the Gadigal and Wongal people. So I'd like to pay my respects to Aboriginal Australians, elders past, present, and emerging, and acknowledge that we're on a land that has not been ceded. And welcome to everybody. So, Carl and Annie, do you want to say hello?
Well, hello from us. We're up in the Blue Mountains, which is much colder than Sydney is at the moment. And once again, would like to express our acknowledgement of people from the lands in which we're staying at the moment, um, elders past, present, and those emerging. Uh,
And hi, nothing else to add.
I'll talk you through the plan. So we have a couple of questions that were put on the Google Doc. We've got a question in the Q&A, so feel free to add to that. We've got some polls. We were going to ask you some questions this evening, and I guess what we're particularly interested in is how the MOOC is influencing or going to influence, hopefully, your clinical practice. We will have a look at some of the people that you have done some intervention planning with. So Phil, who you saw in week 3, and Henrietta, who's in week 4, and ask what your ideas are for training those people, and we'll talk through those plans together. So we'll start with the MOOC questions. And so the first question that we had was about what would be the frequency of training potentially that we would use for somebody who's 2 years post-stroke. And that really relates to a question that's been put into the Q&A so far, which by Nicole, which said that most recovery occurs in the first 12 months. And is there ever a time when you would cease doing therapy, particularly if the stroke survivor is not really motivated to do therapy? So I guess they're kind of related questions really about frequency of therapy and when you might continue or discontinue therapy once you're looking at people that are a year or 2 years post-stroke. So who's starting? Would you like to start, Annie?
Sure. We often get people at workshops who are in this category. And what I would generally recommend is often people can afford to either pay for or will get access in the public health system to a period of maybe 4 to 6 weeks of training. And in that time, you're wanting to be trying as many of the interventions that the evidence says will help elicit muscle activity. So I'm thinking about people who don't have any hand or arm function that they can use. So that would be electrical stimulation, mental practice, mirror therapy, particularly. So the research on mental practice, mirror therapy, typically people have had 1 session a day, 5 days a week for about 4 to 6 weeks. So I'd be teaching people how to use mental practice for perhaps thumb abduction, wrist extension, external rotation of their shoulder, getting them to rehearse mentally those movements. I'd be showing them how to use the mirror for their hand, because obviously it's only useful for their hand, and showing them movements to try and move and replicate with their other hand. And getting them to do that every day, maybe for 5 minutes in the morning, 5 minutes later in the day, or do a little circuit of those activities. Show them how to use electrical stimulation for thumb, wrist, and fingers. And then see at the end of 4 weeks or 6 weeks if there's any change. And then and they know that you've tried these evidence-based interventions in the same sort of dose or duration that they've used in the trials. And it may be at the end of that time, there's still no messages getting to their muscles that they can actively get a contraction from.
Yeah. Yeah.
well, yeah, I think I fully agree with what Annie has just been talking about. I think those specific interventions electrical stimulation, which sort of demonstrates to the person that the muscles are still available to use, but the problem is that their brains aren't sending messages to those muscles. And then the mirror therapy and the other interventions will give them the opportunity to try to get those muscles to work. I would really concentrate on probably finding some muscle activity somewhere. And it's not uncommon to find protraction, even though people are doing other things with their shoulder, using that cardboard cylinder and finding something that they can do. I think for somebody that's so long post-stroke, for them to see that they can do something is motivating. One of the things that we would need to determine in that period of time is how do they demonstrate that they're willing to put the time in? And that would be a critical factor in terms of their own practice, is give them one thing to practice, not multiple things, but perhaps in that first session, just one thing to practice. And if they can do a little bit of protraction, then stick with that would be one of the things that I would do. And then get them to show you how they've practiced in the meantime. Because that's the critical thing for them, is to be able to commit themselves to the practice, which is going to be profoundly difficult.
I was just thinking that often when you ask people do they want to work on their shoulder or their hand, if they haven't got any movement in their hand, they'll almost always say the hand. They want something to move in their hand or their fingers. And it's more often if they've got pain in their shoulder, they might want you to focus on some exercises to help them get some movement there. What about you, Simone?
I don't know if I got anything to add to that. So the question wasn't specific. There was one question about what when people are very weak, but another question that was a bit less specific, but was a bit more around frequency. And I think that's an kind of an unanswerable question, because all services and countries probably have different access to. But I guess really, particularly when you're working with people who are later after stroke, I think we do need to be seen as kind of coaches or guides in that. And there's really, we shouldn't be setting up very frequent therapy sessions for people to do practice that doesn't need to have us in it. That really, we should be really thinking, like Annie was saying before, it's all about teaching people how to do stuff without us as well too. So I think if I say, for example, if I had my own practice and I was seeing people a year or two after stroke, I think maybe I'd try and see them, like once or twice in the first week, and then maybe just once a week or once a fortnight as a review of progress. And tele-rehabilitation could potentially be a very cost-effective and easy way of doing that. And tele-rehab Annie's done quite a lot. I've done some more with lower limb stuff, but that's also a very cost-effective way of providing some ongoing advice to people too. So I think those are the points to think of.
Sorry, Simone, please go.
In terms of that question about the 12 months, I think obviously, people do get most of their recovery early, but it doesn't mean that there's not possibility to get stuff happening further down the track. But I think, like Annie's saying, you might really want to sort of put a time frame on it as well too, like, put in a really solid effort for this period of time so that people feel that they've done that, and then sort of revisit and see what's happened in terms of whether that has elicited some consistent muscle activity.
I think just giving individual clinical examples is not a good way to guide your clinical practice, but in the workshops, as Annie was saying, that we've been doing over the years, I think the longest that we've had somebody post-stroke is 25 years. And they were still able to demonstrate in a 3-day period that they were able to get some active wrist extension. It didn't mean that they had a hand that they could use, but they were able to demonstrate to themselves that they could actually begin to do some wrist extension. Even though we hadn't seen any on day 1, they were able to begin to do that by day 3. So the potential is there, but I think on the other hand, people are going to need to commit themselves to lots of practice. And One of the things that I was going to say, Simone, following on from you, is perhaps if in your clinic you have an opportunity for a group class,
Yes.
people can then drop in, and there is an opportunity for a space for somebody to come and join other people who are practicing and get reinforcement from other stroke survivors, and perhaps a clinical review once every 3 months rather than having a specific sort of time. So there's another way of perhaps offering the opportunity for people to continue to seek muscle activity if that's what they want to do. Um, Quite often for people, they say, this is just too hard. I want to get on with my life and I want to do other things. And that's perfectly okay too. I don't think we have a right to tell people what they should do, but we do have, I think, the responsibility to show them the best things that evidence suggests they could be doing to try to optimize their function.
Okay, I was meant to be cutting us off after a minute each, and we've just spoken for about 2 or 3 minutes each, so I'm cutting us off. Okay, shall we go to a poll, and then we'll come back to there's a few more questions in the Q&A. But I guess one of the things we're particularly interested in is about how the MOOC has impacted or will impact your practice. So can you see the poll, Carl and Annie? Yep. So if you could answer that question, so you can see you're being asked about the same thing, but you're being asked whether you did these things before doing the MOOC is the first question, and once you've done that one, you can go through to the second question, which is exactly the same, but it's really trying to gauge the effect of the MOOC. So you can say the first bit is what you did before doing the MOOC, and the second one is what you're doing differently, I guess, as a result of the MOOC.
And routinely means that you would offer it to people who are eligible and would benefit from those treatments as a routine part of your practice. So if you see people all the time who've had a stroke, you would be offering these interventions very often.
How many people have we got? We've got about 35. Oh yeah, I can see it up here. 22 of 33 people have responded. I'll give you a bit of time. 23. And then we can think about some of the upcoming questions while people finish off the poll. One of the questions that's come up in the Q&A, Carl and Annie, is about functional splints, the sort of splints you might use, to hold somebody's thumb out into abduction to allow them to do practice, not resting, but functional kind of splint. So what are your, really just asking, what are your thoughts about using those?
You want to do that now?
Yeah, we could do that now as people finish off the quiz, and then we'll do the quiz results after that. Yeah.
So yeah, I mean, I think they have a place because they help to position the person's thumb, particularly in the an opposing position. You can sometimes use strapping tape as well. That can sometimes be helpful for getting the thumb in the right position. I've sometimes used strapping tape too to help people keep their fingers flexed or to stop people from hyperextending. So you're really just using those devices, if you like, to try and retrain the brain and the fingers and the thumb to achieve a particular position and to maintain that position. So yeah, the answer is yes.
I think it's sometimes helpful for the brain to remember those shapes. So when somebody's trying to reach and their thumb doesn't abduct, but they can have their thumb in that position to be able to reach with a pre-shaped hand, and the splint is effectively giving them the opportunity to do that. Sometimes that's helpful for the brain to kind of start to get that idea again. So it's worth trying.
Okay, I might go on to the next question, and then we'll share the poll results then. So this is from Zubin Mohammed, who's in Kurdistan of Iraq, asking about repetitions of doing ulnar median and radial nerve glide exercises. So I think the only context in which I know about these nerve glide exercises, Kubin Mohammed, is in, treating musculoskeletal pain problems where somebody clearly has some dural adhesions. It's not something, but I do know that sometimes in stroke rehabilitation they're used sort of almost as part of routine rehab, but there's no reason for them to be used as somebody's rehab unless there's a clear indication that they're contributing to some pain problems or something. And to be honest, I actually don't know enough about because I have never used them in the context of stroke rehabilitation, so I don't actually know enough about their repetitions. I don't know if you do, Carl and Annie, but the place I would suggest where you would find that information, but again, I wouldn't be using them as part of stroke rehabilitation unless there is a very specific indication to use them. I know that you'll find information about them, I think, on the NOI website, NOI, which is a website with a lot of information about chronic pain. So I think that's a place that you could go to find more information. But yeah, I don't know if you want to add anything to that, Carl or Annie.
The only thing I would say is that once you start doing interventions, unless there's a really specific purpose, and you should see a change, within 1 or 2 sessions from doing that intervention, what you're doing is, I'd say you're wasting time, taking time away from other evidence-based interventions that might be of benefit. So, don't try a bit of this and a bit of that just because you think it might be of benefit. You've got to have a targeted reason for any treatment. And it doesn't, lots of things we do haven't got an evidence base for quite a while, but you should see a change in whatever it is, whether it's pain or movement or active movement by the person within 1 or 2 sessions. If you're not seeing any response, then don't do it.
Yeah, I think essentially what is very important about making an intervention choice like that is making sure you measure before and after. And if you don't see a measurable change, then you probably need to certainly question whether in fact it's of benefit.
Okay, so I'm going to share the poll results too before we go on to more questions. So I guess what we're interested in obviously is whether there's change. So this is how much people were routinely using these interventions before the MOOC. So you can see, so lots of task-specific training, and strengthening, but not so much of some of the others. But have quite an impressive change, I guess. And I can understand that. I guess the one that's probably got the least amount of change there is constraint-induced movement therapy, but that is a complex intervention which probably takes some planning. And there are some very good resources that you can use if you have a look at the resources, particularly that Lauren Christie has put out, and there's some further lectures on it too in our recorded lectures. But it's really good, I guess, to see the increase in e-stim, mental practice, mirror therapy, task-specific training, which was high, but now is even much higher. So that's good too. And strengthening interventions has also gone up. So very good to see.
I don't know if people can see the answer to the second question on the screen, so I've just scrolled it up.
Okay. Oh, sorry, I just closed it now. Anyway, I could, actually, I don't know if I can see them, but yeah, I could put some screenshots on the Facebook. Okay, there actually are a few more questions that have come into the Q&A. There's a very long one, but I don't know if I want to leave one of you to read through that maybe and then a short one about just training wrist radial deviation when practicing drinking from a cup.
So I'll see if I can understand the first question from Alison. So she's got somebody who is 2 years after their stroke, learned on use of the affected arm, wanting to be able to hold her walking frame more easily, a bit of pain on wrist extension, has been referred for botulinum toxin, now got more passive range of movement in her wrist and fingers, And he's doing some practice for shoulder, biceps extension, flexion extension, wrist. She's got some activity in her thumb and extension at the MCP joints, especially the index. Has thought about doing strengthening, but doesn't know if that's helpful following the intense trial. So I guess if there's somebody who's having active treatment, and I suppose it depends how much measurable spasticity was affecting her ability to move her fingers. But I guess it sounds like she's getting some movement from what you're saying, some activity, thumb and fingers. So I would keep working with, with what she's got in terms of targeting particular flexion and extension. And then you've got the goal of can he or she hold the walking frame? Yes or no? You've got that to keep going back to.
And you could potentially go back to, I guess, what you were saying at the beginning, Annie, about maybe having some 4 or 6 week blocks of sort of mental practice, mirror therapy, electrical stim, sort of to see how much change you get within a set period of time.
The little or no wrist and hand movement is one of the eligibility criteria for, I think you're referring to some of the studies. And even with, CIMT says you've got to have some finger extension and some wrist extension to participate in a CIMT program, and a little bit of movement somewhere. And with the mental practice and the mirror therapy, while some of the trials didn't include people with who are very weak, you can still use those intervention with people who are very weak.
I think positively from what you're describing from that lady, that she does have some thumb adduction, she does have some muscle activity. The intense trial was on people that had no muscle activity at the wrist and the hand, and the Botox intervention was primarily for the ability to open the hand, and then the convention at that time was then to provide people with the kitchen sink in terms of all of the interventions to try to see if they would get muscle activity. And that particular study was looking at the issue is, does providing the kitchen sink in terms of intervention actually make a difference to outcomes? And that trial over 140 subjects found there was no difference between the groups. But that's in a group of people that had no muscle activity. So that needs to be reinforced. But also the Andringa paper looking at botulinum toxin found the same result for no change in intervention as a result of botulinum toxin alone. So for this particular lady, though, she does have a goal. She wants to be able to open a hand to put it on a frame. She has some inattention to her hand. So both of those things together would provide her with a specific goal. And then the goal perhaps is to be able to continue to hold the frame as she walks along. So there's goals you can build into her training. And that would then give you some measurable way of seeing whether she's changing or not. But it's very positive that you're seeing some muscle activity. It's then actually relating that to some goal that she wants to achieve. And as Annie's saying, maybe her frame and holding her frame is that goal. And would make a difference to her abilities to be able to walk around. So I think it's a very motivating goal for her to try to achieve.
The other thought I had was, she'll be able to drag her hand off the walking frame, but can she actually lift her fingers up off the walking frame handle or off an object? That might be a goal, keeping her palm there, but can she actually lift it off rather than just having to drag it off to actually use her active extension at the MCP joints?
Lots of ideas to explore there.
Yeah, I might move us on to the next one, and then we'll go to another poll. But so this is about the evidence, around prolonged stretch, and it's from Alice and Benbow again, saying that they routinely suggest to people that they maintain some abduction, external rotation when they're at rest. Is this of benefit? I think we probably don't really know that, but it certainly is not going to do them any harm. And it just still seems like a kind of a sensible thing to do rather than have an arm resting always in internal rotation and adduction. So that
And
would
I think the other
be
thing
my
too
suggestion. Yeah.
is to make sure that it's not taking up part of your treatment time, because you've got such
Yeah.
a short period of time
Well,
with
they're
the
really specifying that at rest. Yeah. There.
Mm.
So yeah.
Yeah, I think that the close relationship between loss of external rotation and pain is one thing to keep in mind too. But if the weight of the arm is supported and the person can maintain some or put their arm into external rotation themselves, it's in that realm of it's probably a sensible idea, rather than being always in internal rotation. So
Yeah.
there's no clear evidence one way or the other. There's a new Cochrane review coming out looking at the prolonged low load stretching evidence, and that should be coming out either at the end of this year or early next year. So look out for that. And that will be freely available on the Cochrane website.
We'll put stuff on our Stroke Edge social media to alert you. Okay, here's a really good very specific training question, which from 607876. Welcome to you, 607876. Wondering how to train wrist radial deviation when practicing drinking from a cup. Annie looks ready to go on that one.
So we'd have a straw or something along the top of the got a pen, Carl? No, a pen. No, wait. So you can put a pen inside somebody's jumper. So a straw or something like that. And the target is to try and bring the hand up to touch the. Okay, so hopefully you can see that.
Yeah.
That might be way too difficult for the person, so you might have to bend the straw so that it's, able to touch. What you'll often find with that exercise is that people, if they've got a lot of overactivity in their wrist, that they'll flex. So that's why having a goal above where they're reaching to is important. So that they've got to try and maybe touch a mark on the top of their hand. They've got to touch the marker up to the target rather than bending and flexing towards themselves.
I think following up what Annie's saying, sometimes it's also a benefit to train muscles eccentrically. So coming from that target and seeing if they can lower their hand down slowly, so you can count the amount of time it takes to lower the hand. And it may go from one, very rapidly down to then be able to gradually increase the amount of time that takes, because muscles generate more force eccentrically than they do concentrically. So that's another way perhaps of accessing the person's abilities to be able to start generating force.
Okay, I'm launching a poll. We're asking you, and again, the same thing. It's two questions. Okay, so you can see you've got exactly the same question, but we're interested in what you did before the MOOC, and what you're in the second, same things, but have you started, if you weren't doing them, or have you started doing them, or are you planning on starting to do them? If you had some other fantastic plan that we haven't stuck in there about for increasing amounts of practice, throw it into the Q&A, because that was kind of my list of strategies, but you might have some other ones that you're using as well. And I don't know if you want to have a look, Carl and Annie, while people are doing a poll. There's a very specific question about typing on an iPad, about practicing isolated finger movements.
Okay, here we are. See if I can get this. So this will work for typing as well as for an iPad. So you've got the keys, and you'd have to kind of, I guess, work out what the distance is between each of the keys and where the person's fingers might sit. So if the person's trying to move with typing, often they're trying to move up and down. So they might be practicing this on a piece of card, and you're looking at it's hard for me to do this as a mirror image. And there might be a particular finger that they're wanting to work on, or it might be moving between two targets. Can they do that? And it's got to be done accurately, which you can see I'm not able to do. as a mirror image. So that can sometimes work. They're doing it flat on the table, and then once they come to do it on the keyboard or on the iPad, obviously it's a bit more challenging sometimes because of the position. That can work quite well. Sometimes even just being able to tap on the spot and then being able to move between two locations can work. And then you go straight to the keyboard or the iPad, and then you come back to doing this whole and part practice.
I think just following on from what Annie's saying too is to really look at what they do on the iPad to begin with and where the task starts to break down, and then use strategies such as what Annie's suggesting to begin to be able to give them a specific target to practice. So there's no one size fits all intervention, but what Annie's showing is ideas around external cues and how far a finger can move, and then finding out on the iPad how far does the finger actually have to move, and putting those two things together. So can they move? Can they move how far? And then relate that back to the task.
And which letters are they having problems with? Which keys? And just focus on them, not on all the keys. It's a bit like with handwriting practice. You're not just getting people to practice the alphabet. It's particular letters or combinations of letters that they need to practice, and then they use that to write a whole word, and then they go back to part practice.
Okay, I'm just going to end the poll and share the poll results. Okay, so this was sort of what people were doing pre-MOOC, if you like. So there's been a big jump up in groups and classes. We're having a big debate as we came in about how to word this question, because I was saying I don't think people would have been able to start doing stuff straight away because some of this stuff involves a bit of planning. But there's actually a big change. I was wrong there. There's a big change already in groups and classes from 34% to 77%. So, or maybe that's people planning as well too. Semi-supervised practice, 41% to 67, very good. And family-led, 56 to 80, so a big jump there. Home exercise programs, well, that was already pretty big. Technology, yeah, well, that does involve that's a bit more complicated, but looks like there's either people have started or planning on starting CIMT. So anyway, very, very fantastic to see those implementation bits that you've done or that you're planning on doing. So, because obviously that's
it's very exciting, Simone. I think what you'll probably find in terms of the people involved in those classes that you will see significant change as well, which is very positive, not only for the person concerned, but for you as a therapist, which is very exciting.
Okay, so we've got a couple more questions, which maybe we could cover those off, and then we could also have a look at Phil and Henrietta. So there's a question there about when considering a shoulder with subluxation, if somebody can maintain a grip on a walking frame, is it safe to use their arm? Are there other factors that you consider to minimize the risk of increasing the subluxation? So, do you want to start there, Carl?
If I can jump in on that one, I think there's not good evidence around muscle activity, except to say that in the few studies that have looked at that, those people that achieved changes in muscle activity around their shoulder joint actually reduced their subluxation. So somebody that's actually using a frame and actually starting to use their arm to move something around, it's likely that they will also need to use some muscles around the shoulder joint. So once again, I would need to measure first before you start doing that. But I would be surprised if it wouldn't change their subluxation in a positive way, that in fact would decrease their subluxation. Good thing to do too would be electrical stimulation of the muscles specifically around the shoulder joint while they're actually holding the object, so they're getting a chance for those muscles to contract while they're actually trying to do that intervention to use a walking stick or whatever it is they're trying to hold. Because what the muscle is getting a chance to do is to contract while they're doing the task, and their brain is involved in that task. So yes, I would choose to do that and not avoid it.
And there's another very specific training question, which is another very interesting one, which is about ideas to train hand manipulation for the barber. So the patient's left hand is affected and he needs to be able to hold hair with between index and middle finger.
Okay.
Index and middle finger, yeah, and thumb adduction with index finger to hold comb. Those are being done at two different times. I'm not sure. Yeah, but he's still got weakness in his shoulder as well.
Can I jump in and then obviously
Yeah,
any
yeah.
ideas, but my thoughts would be is to particularly because it's hair that's the person's that they're particularly interested in. I would analyze their where the task is falling down quite specifically to actually get them to hold some hair and then see when that ability to adduct the fingers together starts to break down. So is it when they start to use their lumbricals to bring their fingers together around the comb or the scissors, whatever it is that they need to do, and train that quite specifically. There's a mention here also about the shoulder as well. I would divide those two rather than try to train them both together. I think it's hard enough when you're trying to acquire quite specific skills within the hand. It may also involve the intrinsic muscles within the hand to be able to get those fingers to move around that central point that you need to be able to adjust your fingers so that they can meet together rather than remain flexed and I would be really interested to see whether they have intrinsic muscles within the hand to be able to make, for example, that bud shape, because that kind of implies that ability to use the muscles together. But I would separate that out from their shoulder control. In the longer term, combine them together. But first of all, don't make it too hard.
Yeah, it's going to be very complicated. And, and I guess probably worthwhile, like I say, needing to practice like with hair. So finding a way of doing that, whether you use a doll or one of those hair dressing dolls or something like that to allow that practice.
The other thought that I had is depending on somebody's level of ability, if they've got no capacity to bring their fingers together and hold them together, then that would be the goal. So you maybe want to give them something a bit thicker that they can get their fingers together around something that's thicker and close their fingers. So that's the target. Can they close it and stop you from pulling it? So that might be the first goal. Then once they can manage to do that, can they do what Carl was suggesting? Do that and flex their fingers together without you pulling that out. So it's analyzing, yes, can they do this? Yes or not? And then can they do this plus flex their fingers? And then if there's another part of the task they have to do, can they do that? And then can they put them both together? But yeah, using hair, getting away from that and then using hair, whether it's a doll that you find that you can use, and somebody else's hair that you can practice with when you're actually watching them doing it.
That sounds like a really interesting skill to train.
Yes.
I'd be very interested.
You have to look at the essential components of it all. Yeah.
Very interested to see a video. Very happy to look and examine some ideas. So very happy to do that.
Yeah, if they're happy to share a video for you to share a video on our Facebook, which if they're happy to share it, potentially not showing their face and stuff too, then that could be really good for sharing. But we're very happy to be contacted by email too. If you want a smaller forum to share a video. The next question is about using FES at the shoulder that most programs recommend an on-off function. Would you have a constant on function for task practice? If it's the electrical stim setting for subluxation prevention that you're talking about, Willen, then what most of those studies did is work up to like a 30 seconds on, 2 seconds off, something like that. So it's still a very long work time to rest cycle, but still with a small bit of rest. So that's what we've generally done where we're leaving it on to provide support at the shoulder. If you're using it sort of during task practice, then obviously, you'd have it on. If you're using it to help shoulder flexion, for example, then have it on as somebody needs it to assist their shoulder flexion. Don't know if do you want to add anything to that, Carl or Annie?
I would just say that if somebody does have a subluxation and poor control around their shoulder, then I would leave the subluxation settings on while they're practicing something else. So, for example, they could be practicing protraction or external rotation, but the electrical stimulation is still on while they're trying to practice those other components.
There's another question here, which I think maybe from somebody who's joined a bit later, but it was about, again, about this sort of issue about time frames for intervention. Is there a time when people reach a recovery plateau? And really that's really, I think there's certainly plenty of research showing people making changes long time after stroke, and we've all seen that in our clinical experience. So I guess our answer is no, that there's not a specific cut-off time, but there's probably specific things you want to put in place when you're working with people quite far after stroke, and maybe that's around really having sort of constrained periods of time that they really work very hard to try and get muscle activity back for a set period of time and sort of reassess and see what happens, and that you're setting up ways for people to really be doing the bulk of that without a therapist as well. But there's no time limit on recovery, but it obviously is slower and harder often because we know that you get less neural plasticity when you're out of that early acute stage.
Maybe if I jump in for the second half of that question, Simone, for spasticity, Botox injections are given. Are the therapists in your locality allowed to give these injections? And if not, do you consider the time lag before therapy is commenced? So first of all, my comment would be is that botulinum toxin is not going to change spasticity. It's going to stop the nerve from communicating with the muscle, but the overactivity that's occurring at a nerve level is going to continue. So it doesn't change spasticity. It just stops the nerve from communicating with the muscle. So that's important to understand that. So the mechanism is really that it just stops the nerve from communicating with the muscle. The therapists where we work, the injections aren't done by therapists. It's generally done by either a rehab physician or a neurologist, depending upon who's the person most interested in doing the injections. I think there is some specialisation in the UK where therapists are now beginning to do the injections, and I would strongly advocate that we acquire those skills to be able to do that, because I think we are very well placed to analyse and train people. The advantage of botulinum toxin is really that it helps muscles. It's been shown to allow fingers that are otherwise flexed to be able to relax, and that's clearly shown to be of benefit and decrease the carer burden and the abilities to open the hand and be able to get external rotation and so on. But in terms of its abilities to improve function, that has not been shown to be the case, which is very disappointing.
So I'm going to move us on.
Sure.
Yeah. There's a question from Lydia about walking, somebody getting a lot of sort of overactivity in their arm while walking. And I'm sure we've all seen that in stroke survivors, that it's kind of like I guess we might call it a sort of a motor overflow. If it's, if somebody's walking is not that easy to do, and that, and it's difficult and effortful for them, that can lead to a lot of sort of motor overflow into, or whatever you want to call it, but overactivity in arm muscles. So I think what I would do is maybe practice something, see if he can take it back so that he's doing something easier than walking to start with. Maybe he's doing some weight transfer on and off his affected leg, or just stepping his intact leg forward and back. And can he start to keep his arm a bit relaxed while he does that? And see if he can manage to and have those discussions about really trying to let the arm relax, and see if he can do that while he's doing an easier lower limb activity to start with. I had quite a lot of success once working with somebody with after a traumatic brain injury who was very young guy, and he was very bothered about walking around with an arm that looked like that. And we actually used an EMG biofeedback machine on his biceps, so that it really gave him some good feedback from the EMG biofeedback machine. But you don't always have easy access to something like that. But that was very successful in him, just as that sort of constant reminder to just try and stop, let his arm relax, and then start walking again. Oh, it's beeping, stop, let his arm relax, start walking again. And then it actually really did make a difference practicing with that biofeedback.
I think, Simone, I would reinforce what you've just been saying. I think one of the things I think it's easy to forget too is just how terrifying standing is. And standing and walking is even more terrifying because you're having to move and stand on one leg while you move the other one. So for stroke survivors early after stroke, it's important that they're safe. So a wall behind, maybe practicing where they have potential for support, so they can begin to practice without being terrified. Somebody whose leg doesn't work very well, they're most likely to be terrified. And
Switch everything on. Something, yeah.
Be terrified, we show this apprehension. So beginning to practice from a place where you feel safe, and then gradually decrease the amount of support that you need to use or whatever. So a wall behind you, perhaps a wall next to you as well, and you can begin to start to move around without your arm going up in the air.
Okay, I'm moving us on again. Okay, we're going to have a look at Phil. So people have seen Phil already. I'm just going to share my screen, and there's Phil. And what we wanting you to do is to put into the Q&A what your thoughts were about where you would start with Phil, who is a man who really has no obvious muscle activity in his arm at this stage. I think he would have been able to do protraction, active protraction in something like a cylinder. But what else would you be? I think he's probably about a month after his stroke at this point in time, is in an inpatient rehab setting. When you saw Phil in the MOOC, what were your thoughts about what you would do with him? So I'll give you a minute to put your suggestions into the Q&A, and we'll pipe in with our suggestions too.
Do you want it in the Q&A or the chat, Simone?
Well, I didn't think people could access the chat from what we said earlier, so I think it has to be the Q&A.
You just keep that video rolling, Simone. It's helpful.
Oh, yep, sure. I don't think nobody's putting anything in there. Come on. Put your suggestions in. Hey, Nicole, thank you very much. Skateboard for shoulder forward flexion with a cup. Yeah, so hand positioned around a cup. So again, yeah, I think that's a really good suggestion, Nicole. We don't really see what he can and can't, what he can do if he's better set up to maybe to see if he can actually get some active forward flexion if he's on and Nicole's suggesting all those things that would be useful in terms of really supporting the weight of his arm, reducing the friction, positioning his arm well with his hand positioned around a cup, and then seeing if he can get some active forward flexion. And if he can't get active forward flexion in that position, you could put some electrical stim on his anterior deltoid and maybe add some electrical stim into that practice.
There is one mention from somebody about doing internal rotation first for success and then mirror box. I don't think I would go down the rotation track because most people have some internal rotation. Not everybody, but often they do. So I'd be probably, he must have some external rotation, or his hand would be pulling right into his tummy, I think, at the attempts he's doing there. But it's definitely the external rotation is what he needs to practice more, and some forward flexion.
Yeah.
I mean, my comment is that this is too hard for him.
Yeah.
way of making the task easier. I'd
Mm.
still do his training in sitting. I wouldn't go to supine or any other position.
Mm.
But as Nicole's suggesting, really reduce the friction as much as possible. Provide something that really rolls almost effortlessly,
Mm.
to see
And
what.
I think what Rilan's suggestion is, which is, that he's in sitting, but that we do something to help him reduce his trunk movement. So having him sitting maybe in a chair with a back on it or something that gives him but at the moment, he's not been set up to achieve any success,
Mm.
because
He's also, it's not clear if he's got a goal. I don't know whether reaching to the front of the table is the goal.
His counter, I think.
I think it's being asked to see if he can pick up the counter, which is. Mm.
I really like the idea that's been mentioned here too, that about actually putting something in his hand so he doesn't have to worry about pre-shaping, and he can begin to look at what his shoulder's doing rather
Mm.
than worrying about having to make a shape with his hand as well, which is really very, very hard at the same time.
Mm.
Yeah. Yeah. And Jennifer has suggested e-stim for wrist extension too. So definitely has, a very severe weakness. So putting electrical stim on would be very useful.
Mm.
Sliding on roller. So Laura's just, sliding on roller for the things that it could be used for: shoulder flexion, elbow extension, potentially shoulder external rotation. So those setups that, we've got some pictures in the document that was in week 3 with the strategies for strengthening, but also mental practice, mirror box, electrical stim from Laura.
Mm.
Yep. Mirror box mental practice from Anne. Protraction. Yep. The old in the cardboard cylinder, like Carl's beautiful video. Cardboard cylinder for protraction. Elbow flexion and extension on table. Yeah. And so I think if we're going to do some elbow flexion extension, having his shoulder up here so that he's in a position where you can just get really straight elbow flexion extension, and then down here for his external rotation and forward flexion practice. Cup taped in hand again. Yeah.
I just wanted to comment on one of the suggestions was to prompt him to sit forwards to reduce the movement of his trunk or his torso. What he really needs is an activity that he can actually do successfully, because he's using all these
the trunk movement. Yeah.
movements to compensate to try and get his arm to move. So he needs something that's a little bit easier and more successful, and then you'll usually see less of the compensation.
Yeah.
Telling somebody to stop doing something isn't going to reduce the compensations, because they're using all their available muscle activity to achieve the goal that you've given them.
Okay, shall I move us over to Henrietta?
Hmm.
Okay, so we've got Henrietta here now. Oh, sorry, I just need to move the thing so I can see better. Again, yeah. And I'll just loop that. So again, if you'd like to put your suggestions into the Q&A, whatever you've got access to there, but put your suggestions in for where you could start training with Henrietta. And see, because you can see now you've got somebody who actually does these to have a lot more strength in her arm, but could be doing much more targeted practice.
Are you going to show the second video now, or
Yeah, I've got one of the other videos of Henrietta, or maybe the small objects. Okay, so a few suggestions here are to zoom her on Henrietta here. Yeah, and I think, well, I think you can see people are already thinking down the line of she's missing a lot of components, and just doing this whole task practice is really not going to improve any of those components. So people are really going down the line of sort of breaking it down and practicing specific components, which I think is really the most important thing for Henrietta to be doing at the moment. So the suggestions really here from Anne is, like her thumb abduction and her shoulder external rotation. From Laura, practicing shoulder external rotation with a cup in her hand. Lisa, look at her supination and wrist extension, because it's obviously we do need a better idea about how much she's got, but at the moment what she's practicing is not really probably going to improve any of those components. So it's about sort of separating them out and maybe sort of separating out the transport, the pre-shaping and grasp components, so that she can work on them in isolation with some good feedback about getting into how much forward flexion has she got before she goes into abduction and internal rotation. So practicing some transport, maybe again with something taped into her hand, so that to help her maintain external rotation, because maybe she can lift up something a little bit, but obviously she can't lift up to the kind of height that she's practicing here. But it's a bit unclear, because how much of, we don't know how much she's doing that because of what she can't do, because of what that she can't do with her pre-shaping and grasp as well. What would you like to add, Carl?
Just the one comment I would make is that one of the problems with this intervention is that, in fact, overall she's successful. So she can put all of the objects into the cup, but she's not doing it well. And so it's an example of an intervention which is non-specific, doesn't address her problems, but she's successful. So in fact, in many ways, it's an example of a very poor intervention strategy for her to be practicing, because she's practicing all the things she doesn't need to practice, and that's not going to help her function.
The one, I suppose, the one thing that immediately comes to me is the first thing I would do is give her feedback about, are you aware that you're doing this when you reach, that your arm's coming out to the side? Could you, maybe for the first task, can you pick up the cup without your arm coming out to the side? Can you go straight forwards? Now, she clearly does pronate her hand quite a lot, which suggests to me she's probably got difficulty. She's got some thumb abduction, but perhaps not enough for the size of the cup she's being asked to pick up. And I think a lot of people are showing in their responses in the Q&A that they're wanting to check external rotation because they think that might be a problem. And the position of her elbow shows that she's in internal rotation and maybe does have problems with her external rotation. But first of all, I want to find out, can she do it just with a bit of verbal feedback, go straight forwards without her arm coming out to the side for either of those two tasks, or without moving her body forwards? And maybe move the cup closer to the edge of the table. Yeah.
I think there's some terrific ideas there. I think the idea, first of all, you need to split the shoulder from the hand. So cup in the hand, and can she reach forwards and do all the things that Annie's been talking about? Can she externally rotate? Can she forward flex without abducting? And give her some external cues that she can start to see, perhaps a dot on her medial side of her elbow, so she can actually still keep that dot in view as she reaches forwards. And then I would look specifically at her hand without transport. So can she extend her wrist well? Can she maintain wrist extension and abduct her thumb at the same time? Can she extend to the MCP joints to make the shape she needs to make? And if she can do that, then perhaps it is a shoulder problem. Or if she can't do that, perhaps what she's doing at her shoulder is because of what she can't do at her hand. So we need to be much more targeted as clinicians to analyze where her problem is.
Yeah. Okay, well, I think that takes us to 7 o'clock. So,
very good. Good range of questions, and
yes.
Thanks
Yes.
everybody for joining us.
It's good to have some very specific training questions in this second Q&A where as we have moved on a bit more too into more task training. But yeah, thank you very much for joining us, and just a reminder that the content of the MOOC stays open till the 20th of July to allow for time zone differences. It will be actually the midday on the 21st in Australia, but for the rest of the world, it probably will be the 20th of July. So keep 20th of July in your head. I think is probably the best way to approach that. And we really cannot extend beyond that date. So I know we're about to get about 200 emails asking that question, but we really can't, because it actually takes quite a lot of IT working away in the background to keep it all up and running. So you've got till the 20th of July. Anyway, there's an evaluation form, so we'd really like to know any of your suggestions for improvement too. We just love hearing from you, and how you're going with the information and how you're going with implementing change, because we all know that implementing change is an extremely hard thing to do. But so we're there behind you, and we'd love to hear your stories about that. But anyway, thank you very much for joining us this evening or morning or whatever time of day you are in.
Bye, everybody.
Goodbye.